Okay, hello everyone. I guess we can give a couple more minutes for people to join as they transition from the main stage to their workshops. In the meantime, if someone could confirm that they can see my full screen, that would be great. Okay, yeah, I see a thumbs up. Thank you. So I will start again. We can start in 1 minute. But in the meantime, I would like to introduce myself. My name is Maria Stamu. I'm an endocrinologist and a physician scientist with a special interest in reproductive endocrinology. And for the next hour and a half, I would like to go over some cases of reproductive endocrinologists, cases of patients that we see at clinic, at adult endocrinology, reproductive endocrine clinic, starting from some more common and more basic cases. And as we go through the talk, some more complicated cases too. So this session, this workshop should be as interactive as possible. So I'm going to invite everyone whenever they have a thought or an answer to a question to either unmute yourself and share your answer or your thought, or use the Q&A or the chat to type questions. I will have some multiple choice questions along the cases. So please feel free to type in the chat or in the Q&A session, in the Q&A box, your thoughts there. So I think we should be, I see there 22 people who have joined. So maybe we can start with the first case, which is a 32-year-old female who presented for evaluation of irregular menses. She reports that menarche started at age 13, and menses were regular up until 2 years ago. Since then, she's been having 8 menstrual cycles per year, with the longest time frame without menses being about 4 months. So based on the information that she has given so far, how would you define the irregular menses that she has? Which term would you use if someone wants to type in the chat or unmute and share? In other words, would you call this primary amenorrhea? Would you call this secondary? Will you call it oligomenorrhea? How would you call it? Can I give a minute for people to think about it? Okay, if we don't have any thoughts, just to remind everyone, and I know tomorrow is going to be the full day of adrenal and reproductive endocrinology, so we're going to go over this in more detail. I see Denise says oligomenorrhea, which is great. Yeah, it's right. So just to remind everyone, primary amenorrhea or amenorrhea is the absence of menarche by the age of 15. Secondary amenorrhea is the absence of menses for more than 3 months in girls or women who previously had regular cycles, or 6 months in girls or women who had irregular menses. And oligomenorrhea is fewer than 9 menstrual cycles per year, or cycle length greater than 35 days. So based on the information she has given us so far, she has oligomenorrhea. I agree with Denise. And also some secondary amenorrhea, an episode of secondary amenorrhea at the time when she reported not having menstrual cycles for longer than 4 months. So typically when you see a patient like that at clinic, would anyone want to share what type of questions they would ask? So a 32-year-old female coming in with irregular menses. What would be a couple of questions you want to get from the medical history? You can either unmute, maybe something very simple and straightforward, or you can type if you want to, if you prefer. I see David says clinical features of hyperandrogenism, correct. And what diagnosis would you think when you ask about hyperandrogenism? PCOS potentially, perfect. So yeah, great. So we want to ask someone who is, a woman of reproductive age with irregular menses, whether she's been sexually active, so any chances of pregnancy. That's the first thing we want to rule out. But you're right, David, we want to ask for any signs of acne, hirsutism, or hair loss, thinking about PCOS in our differential diagnosis list. We also want to ask for any hot flashes, night sweats, or vaginal dryness. Could someone want to share why we would ask those questions? I mean, what diagnosis would suspect? Premature menopause, premature ovarian insufficiency, POI, ovarian failure. Perfect. And galactorrhea, mainly when we think about hyperprolactinemia, that is contributing to disorders of reproductive access and irregular cycles. Any vision changes, double vision, headaches. If you want to, get some more information about the possibility of a pituitary mass or a pituitary adenoma affecting the axis, any features that are linked to growth hormone disorders, any coarsening of the features, enlarging of hands and feet, excess sweating, deepening of the voice, skin tag, sleep apnea. Does anyone want to share what condition could lead to irregular cycles that's also linked to weight changes, easy bruising, thinning of the skin, striae, abdominal pain, nausea, vomiting? Cushing's, yes. Hypercortisolemia can suppress production of gonadotropins in the pituitary and lead to irregular menses. And then any signs of fatigue, skin, hair, nail changes, heat or cold intolerance, palpitations, constipation, or hyperdefecation, thinking about thyroid disorders. In addition to all of our endocrine system and different endocrine causes of irregular menses that we want to assess when people present with irregular menses, there are some other questions that we want to make sure we get from the history. A big one is that if there are any dietary changes and like the level at which someone exercises, and would someone want to share what we want to rule out when we ask, or rule in when we ask about dietary changes, restricting eating, or excessive exercise? How we would call the condition of irregular cycle? Oh, I see people say anorexia nervosa, anorexia, low BMI, hypothalamic amenorrhea, also in the Q&A chat, HA. Yeah, so we want to make sure or figure out if there are any signs of hypothalamic amenorrhea. So we now know that it's not only the low BMI that is linked to anorexia nervosa that can suppress the HPG axis, the hypothalamic pituitary gonadal axis, but more the percentage of fat mass in someone's body. So someone's BMI may actually be in the normal range, but because their fat mass storages are very low, leptin is not produced at enough levels, and then there is some disruptions in the HPG axis. Also to assess if there was any recent stress, any recent hospitalization, any major surgery, again, thinking about causes of suppression of the HPG axis. Any history of obstetrical surgery, thinking more about anatomical conditions that could lead to irregular menses. And then finally, a very important one is the medication list of our patients. For sure, I mean, we would expect that someone who presents with irregular periods, they don't mean that they do take birth control pills, but that's something that we typically see at clinic too. So we want to make sure we assess for usage of oral contraceptive pills, other medications like androgenic medications, and an important category of medications are the ones that are linked to high prolactin levels. As we know, hyperprolactinemia has an effect on the hypothalamic pituitary gonadal axis. I have tried kind of like to summarize the most important, like the big players of medications that they are linked to hyperprolactinemia. And we know that first and second generation antipsychotics through a dopamine 2 receptor blockade lead to hyperprolactinemia, and they typically cause irregular periods. And very, big players here is the haloperidol and risperidone from the first and second generation antipsychotics. Cyclic antidepressants have also been associated with hyperprolactinemia, as well as GI medications, mainly metoclopramide and antihypertensive, mainly methyldopa, and then finally opioid analgesics like methadone, morphine, and others that have an indirect effect in the mu opiate receptor activation, leading to hyperprolactin. But we also need to keep in mind that those medications can also suppress FSH and LH production in the pituitary, so there can be multiple mechanisms by which they can lead to irregular periods. Then apart from the medical history, I'm sure everyone is very familiar with the physical exam that all of our patients undergo in the reproductive endocrine clinic. But just briefly to summarize, we always want to assess the BMI. As we said, the BMI per se may not be an indicator of hypothalamic amenorrhea. It's rather the fat mass storage in someone's body. But lower BMI is usually linked to HA, and then higher BMI some of the times is linked to PCOS. We also want to assess for clinical signs of hyperandrogenism, like hirsutism, acne, and then any other signs in the skin that are linked to Cushing's that some of you correctly mentioned earlier, like striae, easy bruisability, and then finally acanthosis nigricans that is linked to insulin resistance in our patients with PCOS. Just to remind everyone how we assess clinically the hirsutism during physical exam, we do use the Ferriman-Gallwey scoring system that assesses the hair distribution in 9 different body areas, including the upper lip, the chin, the chest, the upper and lower abdomen, the pubic area, arms, inner thighs, upper and lower back. And the scores go between 0 and 36. And does anyone want to share, or do you know what the cutoff is for the score to say whether someone has clinical hirsutism? Just in case anyone shares. So from the initial publication from 1961, the cutoff that we use to assess clinical hirsutism is 8. I do need to mention, though, that was assessed in Caucasian women. So that changes a lot based on the ethnic origin of our patients. So there have been publications, for example, in Asian Chinese women that have suggested a lower cutoff that we should use to assess clinical hirsutism in our patients. So in that population, a cutoff of 5 has been validated as the cutoff at which we do make the conclusion that someone has excessive hair growth. And then finally, breast should be examined for the evidence of galactorrhea. And it is also recommended that we also do an evaluation of the external genitalia of our patients, mostly to assess for evidence of clitoromegaly, which is an enlarged clitoris larger than 2 centimeters. So after we have completed, let's say we've completed the medical history, the physical exam, and we go back to this 32-year-old female, our first case with the irregular menses. She tells us that she has been experiencing worsening acne and hirsutism since the age of 16. 2 years ago, she noted her weight going up, and she has been struggling to lose weight. Her review of system is otherwise negative. On physical exam, her BMI is 32, and she's noted to have hirsutism in her upper lip, in the chin, in the lower abdomen, and the thighs. And she has a Ferriman-Gallwey score of 12. She does not have any galactorrhea, no striae, no thinning of her skin, and the genitalia are normal development. So based on that, which of the following tests would you order? So if people can type their thoughts in the chat or the Q&A box in terms of what you would choose, that would be great, and we can go over them together. So first option would be TSH and prolactin, A, B would be day 21 progesterone, C would be day 3 FSH, late estradiol, testosterone, DHEAS, and 17-hydroxyprogesterone. E, and there's some combinations we can do. We can do A and D, A and B, or A and C. So I see someone says C, someone says G, a lot of G's. Okay. C, G, perfect. So for this question, the correct answer is G. C is not wrong. It's part of the labs that we want to get. And I will just go over what is the baseline test that we get and how we select each test in each occasion. So typically, I mean, for every female patient presenting with irregular periods, oligomenorrhea or amenorrhea, we always check a serum HCG level. We want to make sure that she's pregnant. She's not pregnant. So if it's positive, then pregnancy needs to be verified. But if it's negative, we start with a baseline day 3, FSH, estradiol, TSH, and prolactin. And if there is any evidence of hyperandrogenism, we want to add testosterone, ovarian and adrenal androgen, testosterone, DHEAS, and 17-hydroxyprogesterone. And then based on this initial evaluation, if there is abnormal TSH, we want to make sure we evaluate for thyroid disorder and treatment of it. I mean, I know you had a full day on thyroid disorders today. If it's elevated prolactin, we always want to make sure it's fasting. We may want to get a pituitary MRI. High FSH would indicate premature ovarian insufficiency, whereas low or normal FSH with low estradiol makes us think of a hypothalamic cause of suppression of the hypothalamic pituitary gonadal axis, like hypogonadotropic hypogonadism, hypothalamic amenorrhea, a pituitary adenoma suppressing the axis, and in that case, we would obtain a pituitary MRI, and high androgens would lead to us thinking about PCOS. And in her case, because she had the acne, she had the hirsutism, she had the irregular cycles, we always want to assess those 4 labs are baseline because are the most common endocrine causes of irregular menses, and then add on the androgen evaluation. Just very briefly reminding everyone why we get day 3 labs. We all know that during the menstrual cycle, we have the follicular phase during which the follicle recruitment is happening. And then right after the LH surge, ovulation occurs. And also estradiol rises right before the ovulation and then is decreased during the luteal phase, with progesterone being decreased in the second phase of the cycle, or the luteal phase, which always lasts for 14 days. So the reason we want to get day 3 labs is mainly to assess whether FSH is low or high. So a high FSH level on day 3 would be indicative of a premature ovarian insufficiency. If we were, for example, to measure FSH close to ovulation, we may actually get a higher level here that is linked to the ovulation phase, and then that would mislead us in making the diagnosis of POI. And then progesterone, we can check it whenever we want to assess whether someone is ovulating. And I know typically, books may say day 21, but it's always, we prefer to check it 1 week prior to the next expected period. We know that the luteal phase is always 14 days. So in the middle of the luteal phase, so 7 days before the expected period, we check a progesterone level. So if someone has a cycle, instead of 28 days, if they have a cycle of 30 days, then ovulation is probably going to happen on day 16, so 14 days before the next period. And we then add 7 days from that, and that would be day 23 that we check the progesterone level. So sometimes we also may want to assess the estrogen status of our patients. And to assess the estrogen status, we can use a progesterone withdrawal test, at which we administer medroxyprogesterone 10 milligrams for 10 days. And if there is a withdrawal bleeding, that seems that the patient has been exposed to endogenous estrogen, and that would be the case in someone who has polycystic ovarian syndrome. But if there is absence of bleeding, that could be either due to a low estrogen status, for example, someone with hypothalamic amenorrhea, someone with hypogonadotropic hypogonadism, or an outflow tract disorder. And then may I ask, would anyone get an ultrasound, a pelvic ultrasound, to make the diagnosis in this case? Lizette says no. David says Rotterdam criteria already fulfilled. Perfect. Great. So the patient has irregular cycles and she has hirsutism already. So she meets the criteria for PCOS. Sometimes we may get a pelvic ultrasound if we want to assess the estrogen status mainly to assess the endometrial thickness. So if someone has had amenorrhea for a long time, in addition to giving medroxyprogesterone, we may get a pelvic ultrasound to assess the thickness before starting a birth control pill, or to know whether to give Provida or not before starting a birth control pill. If patients do not meet criteria for PCOS, we can get an ultrasound to assess for polycystic morphology. And also, it would be important to assess for any structural abnormalities when labs are all normal and the hormonal evaluation is normal. This is a slide that Judy Adams, who has been the ultrasonographer for many, many years in the reproductive endocrine clinic, has very kindly shared with me that shows some alterations in the lining of the patient here, which actually followed some instrumentation that the patient had to do at DNC. So that can sometimes give us a clue of why someone may have irregular cycles, or more importantly, when someone is trying to conceive and there's some inability to conceive. So back to our case one, these are her labs. So she has a negative pregnancy test. She has an FSH of 4.6, LH 12.8, estradiol 34, TSH prolactin normal, slightly high testosterone, DHAS 326, and 7-hydroxyprogesterone less than 40. So someone, David has already shared that she meets Rotterdam criteria for polycystic ovary syndrome. So we can safely, confidently say that she has PCOS. And I know you're going to have a full session about PCOS tomorrow, but just very briefly in the next couple of slides before we move to our next case, I'm going to remind everyone that PCOS is a very common complex genetic disorder, and it affects about 50% of women in reproductive age. And the Rotterdam criteria include oligo or anovulation, clinical or biochemical signs of hyperandrogenism, and polycystic ovaries in ultrasound. And patients need to fulfill or meet 2 out of the 3 criteria. And this mainly speaks to the heterogeneity by which patients with PCOS may present. As we discussed, an ultrasound may not be needed in most of the cases. And the reason is that PCO morphology is seen in about 93 to 100% of women with PCOS who have oligomenorrhea and hyperandrogenism. In addition to that, PCO morphology by itself is very common. So women with regular menses and PCO morphology and ultrasound are not at increased risk for development of PCOS. And again, Judy very kindly shared with me this image of an ovary with polycystic morphology, where we see multiple follicles in the periphery of the ovary with increased stroma. And criteria used to be that to define PCO morphology, we need 12 or more follicles or an ovarian volume less than 10 cc's. In the most recent updated guidelines that were released last year, now that we have higher resolution ultrasounds, the number of follicles has increased to 20. So we need to see more than 20 follicles in the ovary, and then the volume remains greater than 10. And we can see in contrast on the right, an ovary that does not have PCO morphology, where there are fewer follicles, they're not distributed in the periphery, they have random distribution, and there is not increased stroma. Now, in terms of the pathophysiology of PCOS, we know that there is some alteration in the secretion of FSH and LH from the pituitary with an increased LH to FSH ratio. So in PCOS, we have elevated LH levels that stimulate the ovary and lead to increased production of ovarian androgen. In addition to that, decreased FSH levels are linked to chronic anovulation and decreased cyclic estrogen production. The overproduction of androgens from the ovary, in addition to the increased androgen levels from the adrenals, lead to increased aromatization of the androgen in the adipose tissue for E2 production. And this increased non-cyclic estrogen production then also leads to a further decrease in the FSH levels. And this is the reason why women sometimes present with irregular periods and more signs of hyperandrogenism, more severe signs of PCOS in periods after they've gained some weight. So it's that increase in the adipose tissue that leads to more increased non-cyclic E2 production that makes this vicious cycle worse. So after we've gone through case one, let's say that the same patient, 32-year-old female patient with irregular cycles, this time she had a 17-hydroxyprogesterone level of 275. What condition would you be suspicious for in this case, if someone wants to share? Perfect. I see Louise, Dennis, non-classic CAH, non-classic congenital adrenal hyperplasia. And which lab would you like to see in addition to 17-hydroxyprogesterone level? Is there a lab that could tell us whether this level is reliable to make a conclusion in terms of her diagnosis? People say concentropin test, ACTH test. Even before we go, that's the right answer. We want to do an ACTH concentropin test to verify the diagnosis. But even before that, oh, I see, Claire says progesterone. Great. And the reason we want to check progesterone is we want to see whether this level was checked in the follicular or luteal phase. So we get the progesterone in this case, and it's 0.8. So we think most likely, it is in the follicular phase. So the level is 275. And then based on what we discussed, what would you like to do next? If people, again, want to type in the chat. Do you want to repeat it on a different day? Start therapy, get an ACTH stimulation test, or start therapy with glucocorticoids or oral contraceptives. Perfect. So everyone wants to do C. So we want to get an ACTH stimulated 17-hydroxyprogesterone level. So before we go to the diagnosis of non-classical CAH and treatment, I'm going to very briefly remind everyone who has joined us today how CAH may present in a reproductive endocrine clinic, and when do we need to approach it? So CAH, or congenital adrenal hyperplasia, is a group of autosomal recessive disorders that is mainly characterized by impaired cortisol synthesis. The incidence can range from 1 in 14,000 to 1 in 18,000. However, it can go much higher in people from certain geographic regions or certain ethnic backgrounds. What is important to know and to remember is that CAH is a group of disorders. So it's a group of 7 autosomal recessive diseases that is caused by mutations, could be caused in mutation in different enzymes in the pathway. Out of all those enzymes, and we're going to go over a couple of them just to look at the differences, the one that is most common is the 21-hydroxylase deficiency that can lead to classic and non-classic CAH. So it accounts for 95% of all CAH cases. And then brief reminder of our steroid synthesis pathway. So in 21-hydroxylase deficiency, when we have deficiency of this enzyme here, we have low production of cortisol and aldosterone. And due to the negative feedback loop, that leads to an elevated ACTH, and that makes the cortisol synthesis pathway to be shifted to the left. So we have the high DHAS, the high testosterone, and the marker, the one that we measure at clinic, is the 17-hydroxyprogesterone level that is indicative of the presence of classic or non-classic CAH. So let's see a little bit what is the difference between classic and non-classic. It all has to do with the severity of the enzyme deficiency. So in severe enzyme deficiency, we have a classic form of CAH. In less severe, we have non-classic form of CAH. Remember, both conditions are autosomal recessive. So in both conditions, people inherit an affected allele from mother, an affected allele from father. It's the severity of the mutations that inherit that is linked to the severity of the enzyme deficiency and the presentation of classic versus non-classic. It's also important to remember that this is kind of like a continuum, a spectrum of presentation. So depending on the severity of the alleles, people may have some phenotypes in between. So, but just to go over the differences. So in the classic form of CAH, it's like 95% of the cases, it's mutations in the CYP21A alpha 2 gene, the 21-hydroxylase gene. It typically presents in newborns, and newborn females may have abnormal development of external genitalia with evident virilization. And in 75% of the cases, the enzyme deficiency is that severe that can lead to adrenal crisis. So inadequate aldosterone production, leading to salt wasting, failure to thrive, hypovolemia, and shock. And it is part of the newborn screening, at which a 7-hydroxyprogesterone is measured, and there is a cutoff that's used above which the diagnosis is made. And it's very important not to miss such a diagnosis in newborn screen. In the non-classic forms, we have mild subclinical impairment of cortisol synthesis. As a result, those patients are not diagnosed in newborn years or in childhood years. It does not lead to a Addisonian crisis. And most patients with a non-classic form will not be identified in the newborn screen because you need high levels of 7-hydroxyprogesterone in the blood sample to detect that. Typically, in the adult endocrine clinic, people with a non-classic form will be females who may present with hirsutism, acne, hair loss, irregular cycles, and clitoromegaly. In addition, I would like to go over 2 more enzyme deficiencies because they are linked to virilization, and it is important to know those 2 in terms of the differential diagnosis, especially when the genetic screening test for 21-hydroxylase gene is negative. In addition to the 21-hydroxylase enzyme deficiency here, 11 beta-hydroxylase deficiency may also lead to classic and non-classic CAH. It's this gene here that is codes for this enzyme here, but when it's deficient, we still have low aldosterone and cortisol, and that leads to the feedback loop, increasing the levels of ACTH and increased levels of 7-hydroxyprogesterone. However, in addition to the increased levels of 7-hydroxyprogesterone, the increased levals of DHEAS and testosterone that we see, we also have high levels of 11-deoxycorticosterone. And 11-deoxycorticosterone has a mineral corticoid action. And as a result, those patients do not have hypotension, but rather may have hypertension with signs of virilization or excess clinical of excess hyperandrogenism. So that's something that differentiates the 2 conditions. And in addition to that, to the 7-hydroxyprogesterone, we can always, in those patients, we can always measure 11-deoxycortisol in response to ACTH. And when the level is more than 5 times greater than the upper limit of normal, so more than 4,000, it has been shown to be specific for detecting a mutation there. So this is the cutoff that we typically use. So, and then finally, the third condition that is also linked to virilization in females is the 3-beta-hydroxysteroid dehydrogenase type 2 deficiency, in which we have deficiency of this enzymatic step here, As a result, we have low aldosterone and cortisol. These are all linked to low cortisol levels. But 17-hydroxyprogesterone is not elevated. In contrast, we have 17-hydroxypregnenolone that's elevated. And similar to the 11-deoxycorticosterol, we can also do an ACTH stimulation test and measure 17-hydroxypregnenolone before and after. And when there is an elevation more than 10 standard deviations from the baseline or more than 4,500 nanograms per DL, this is when we are confident that this is most likely the cause for the CAH. The interesting part of this enzymatic deficiency is that we have elevation in the DHAS level rather than the testosterone level. And as a result, that may actually link to some feminization in male newborns because of the low testosterone level and low DHAS. So if we were to summarize all those enzymatic deficiencies that are associated with hirsutism and irregular menstrual cycles linked to congenital adrenal hyperplasia, the 21-hydroxylase deficiency is the most common form. It's linked to hypotension, sometimes depending on the severity of the enzymatic deficiency, hypotension or normal blood pressure, virilization without feminization. In the 11-hydroxylase deficiency, we don't have any salt wasting syndrome, remember, because we have the 11-deoxycorticosterone that's elevated. So that's actually associated with hypertension, signs of virilization, and no feminization. Whether in the 3-beta-HST deficiency, again, we have low blood pressure, virilization, and feminization. From now on, when we talk about the classic and non-classic CAH, I will mainly refer to the 21-hydroxylase deficiency because this is the most common, and this is the one where most studies have been conducted. But before we go into the clinical presentation and management, any questions so far? Okay. And feel free to unmute yourself to ask questions or type them in the chat along the way. We will save some time for questions at the end too. So for people presenting with a CAH, depending again on the severity of the enzymatic deficiency, we may get severity of clinical presentation. And here in this great review in the New England Journal of Medicine, we can see the clinical phenotypes in blue that are linked to the enzymatic deficiency per se, to the congenital adrenal hyperplasia. But also there is a lot of symptoms in those patients that are linked to treatment-related conditions. So disease-related clinical phenotypes include early puberty, and the mechanism for early puberty in those patients is not exactly clear. It seems that adrenal androgen levels can prime somehow the pituitary and activate it a bit early. And most of those patients, of course, they may actually present with premature adrenarche in the setting of having elevated adrenal androgen. But there's also an earlier puberty that is noted. Also, they may get symptoms from decreased cortisol, decreased aldosterone, increased androgen, and sometimes the nodular hyperplasia and tumors may be present in the adrenal glands. They may actually have accelerated childhood growth and early epiphyseal fusion in the setting of having higher androgen levels. Androgenization effects in their brain that has been shown in MRI studies, hyperpigmentation from the high ACTH levels. And you can actually see that there are some features here in this image that have something that says CAHX, which is like abnormal cardiac structure, hyperextensibility, male partner, here joint hypermobility, that they actually are linked to the Ehlers-Danlos syndrome. The reason why we may see some of those symptoms in people with classical and non-classical CAH, mainly with the classical form, is because the gene that it's encodes for 21 hydroxylase, the gene that's the CYP21 alpha 2, it's in close proximity with this gene here that is TNX beta. And due to the presence of some pseudogenes in close proximity to the gene, there is a lot of crossover in this chromosome. And this region is very prone to deletions. As a result, when the TNXA and TNXB genes are affected in deletions that also harbor the CYP21 alpha 2, then there is the it's actually the tenascin X gene, then there are some features of Ehlers-Danlos syndrome. So even though sometimes we know we may be busy at clinic, we may assessing people for PCOS, but we want to rule out non-classical CAH, getting a history of joint hyperextensibility or hypermobility or heart history can actually give us some clues pointing to a form of CAH that is involving the TNX beta and alpha gene. Now, in terms of the genetic difference between the classic and the non-classic forms of CAH, there are more than 300 mutations now that have been described in the gene of CYP21A2. And there are some large deletions that ablate the enzymatic deficiency and can actually compromise 50% of the alleles. And in about, as we discussed, 5 to 10% of the patients, those deletions may involve the TNX beta gene, leading to a hypermobility presentation that we see with Ehlers-Danlos syndrome patients due to the haploinsufficiency of the gene. And then the genetic mutations in those alleles may lead to complete loss of enzymatic function to partial enzymatic activity. So depending on how severe the mutations are, the enzymatic function is affected, and then the clinical presentation is dependent upon that. In contrast, in the non-classic form of CAH, it's mostly point mutations. They preserve about 20 to 50% of the enzymatic function, and those account for the non-classic form of CAH. And because most of the patients are compound heterozygotes, meaning that they inherit one mutation from the mother in the gene of 21 hydroxylase and a different mutation from the father in the same gene, there could be a wide spectrum of phenotypes. So we may see people with a non-classic form of CAH that have one severe affected allele from one parent and a very mildly affected allele from the other parent. And their presentation may be more severe with worsening hirsutism. Those may be the patients that do not pass the cortisol cutoff in the cortisol stimulation testing. And they may be the ones who have struggled more with infertility, as we will discuss. Now, in addition to the classic form of CAH that is, it's usually captured, it's treated in the pediatric endocrine clinics, the non-classical form of CAH typically presents later in life. It presents in adulthood. And if it presents earlier on in childhood, it's a symptom of it's usually linked to premature adrenarche. Females typically present with hirsutism, acne, hair loss, irregular menses. And then males with a non-classic CAH is very, very tough to capture. If captured, they may have premature puberty, whereas infertility and testicular adrenal rest tumors are mostly seen in patients who have the classic form of CAH. And then this is mainly a graph from the same review showing that the severe mutations are linked to classic salt wasting presentation, whereas the more point mutations, the milder one, can be linked to non-classic forms, maybe premature infertility, and some of them may not link to any symptoms at all. And that is actually reflected to the level of 17-hydroxyprogesterone levels. So we know that the 17-hydroxyprogesterone levels can go up in the luteal phase of people who do not carry any affected alleles for CAH. And that's why we want to capture them in the follicular phase. And that's why it is important to always check a progesterone level with a 17-hydroxyprogesterone level. There seems to be some overlap between people who do not carry any mutations and people who are carriers, meaning carrying one affected allele only, in terms of their basal and stimulated 17-hydroxyprogesterone levels. Typically, however, people who do not have any mutations, their follicular level 17-hydroxyprogesterone levels are, less than 100. Now, people with a non-classic form of CAH tend to have higher levels, both baseline and stimulated, and people with a classic form, can have extremely high levels of 17-hydroxyprogesterone level. For this reason, the Endocrine Society has released some guidelines in terms of when to screen and how to screen. So we always want to get a morning follicular level phase, 17-hydroxyprogesterone level. If it's less than 200 nanograms per DL, 21-hydroxylase deficiency, it's excluded. If it's greater than 1,000, then we can make the diagnosis of 21-hydroxylase deficiency or non-classic CAH. When it's in the gray zone, where very similarly to how our patient presented, then we do, as most of you said correctly, a cortisol stimulation testing. If the stimulated levels are less than 1,000, then it's excluded. And if it's greater than 1,000, then the disease is ruled in. Having said that, if you have a patient who stims to 17-hydroxyprogesterone levels at 800, 900, typically you can say it's excluded, but you may not be completely sure. And especially if those patients present with a desire to achieve a pregnancy and present for fertility evaluation, it may be important to advise genetic screening testing, because that will be important for how the pregnancy is going to affect it, and also for assessing the risk for having a child with a classic form of CAH, which can be very detrimental at the newborn stage. So according to the Endocrine Society guidelines, genetic screening is ordered if the cortisol stimulation testing, the 7-hydroxyprogesterone level are not exactly clear, are equivocal, and if the CST testing cannot be performed. I would add here that if the couple is interested in fertility and they tend to have 17-hydroxyprogesterone levels at the higher end of normal, I would still recommend getting genetic screening testing. Most of the medical genetic clinics recommend starting with the CIP21A2 locus, because that's the one that's mutated in 95% of the cases. However, if mutations are negative, it would be worth expanding to the other genes. And we have had cases where the genetic screening has been completely negative in our patients, but we still have high suspicion based on their clinical presentation, based on their STIM test. And in that case, we can assume that it's most likely they carry a mutation that has not been yet described or has not been captured by current screening tools. So it could be a mutation in the non-coding region of the CYP21A2 or in the regulatory regions of the genes that were not currently captured. And that's definitely a discussion to have with our patients. So let's go, based on what we just discussed, let's go to case 2. This is a 22-year-old female who is evaluated for oligomenorrhea and hirsutism. She had menarche at age 11, and her menses were regular until age of 14 when she developed oligomenorrhea. Her last menstrual period was 2 months ago. She has noted increased hair growth on her chin, above her upper lip, and to a lesser degree in her back. She takes no medications, and she's not interested in pregnancy at this time. On physical examination, she has some facial hirsutism and acne. She has a pelvic ultrasound that has been already done, and that shows PCO morphology. And these are her labs. I'm gonna let you, take a look at them just to go over them. FSH is 4.6, LH is 8.8, estradiol is 44, prolactin and TSH in normal range, total testosterone 50, DHAS 448. Her 17-hydroxyprogesterone in the follicular phase was 397. And after a cortosis stimulation test, it peaked to 1645. So based on her presentation, which therapy would you choose? Again, if you can type your answers in the chat, or if you want to mute and share. A would be hydrocortisone, 10 milligrams in the morning and 5 milligrams in the evening with fluorocortisone in the morning. B is hydrocortisone in the morning, 10 milligrams, 5 in the evening without fluorocortisone. C, spironolactone. D, prednisone, 5 milligrams daily. E, combined oral contraceptives. Okay, so we have a lot of different answers. I'm glad to see how active the chat is. So we have someone saying B, hydrocortisone without fluorocortisone, combined oral contraceptives. A few people have said E, prednisone 5 milligrams daily. So most people are voting for E. And in that case, E is the right answer. The reason is that this individual presented, so based on what we discussed, I think we all agree that she has non-classic CAH, her 17-hydroxyprogesterone stim to greater than 1,000. She has all the, the clinical presentation of the irregular menses, the hyperandrogenism. And the clue in the case is that she's not currently interested in pregnancy. So she mainly comes in for regulation of periods and for management of her clinical signs of hyperandrogenism. And which is very, very, very similar to how patients with PCOS present. And when our patients present with this indications for treatment for irregular periods and hyperandrogenism, we tend to treat with oral combined birth control pills. And I'm going to show you in a bit why we do so. But just to, kind of like comparing and contrasting PCOS with the non-classic form of CAH, PCOS is, they present very, very similarly, but PCOS is way more common. So it's like in 50% of the general population compared to 0.5% in the Caucasian population, with being more prevalent in the Mediterranean, people from Mediterranean regions, Hispanic and Ashkenazi Jewish population. A patient with PCOS and a patient with a non-classic form of CAH, they will both present with amenorrhea or oligomenorrhea and hirsutism. And they will both have PCO morphology and ultrasound. The difference will be in that elevated 7-hydroxyprogesterone levels. And in terms of therapy, in PCOS, we may start birth control pill and anti-androgen, or whereas in the non-classic form, we will do oral contraceptive pills, mostly because there have been studies that shown that whether we give actually giving birth control pill compared to glucocorticosteroids in those patients may even better control the hyperandrogenism, the signs of hyperandrogenism, avoiding giving our patients the side effects that glucocorticoid therapy may entail, especially if we need to titrate up for control of the symptoms. I would like to hear, would anyone, let's say, she gets oral birth control pill. Her signs, her hirsutism is somewhat well controlled, but she's not actually completely treated. Would anyone add spironolactone in this case? What do people think about spironolactone? Okay, yeah, we have an answer. It would be okay with spironolactone because aldosterone should be preserved. Great, and that's actually the point I would like to make. So for people who have classic form of CAH or for people that we have done laboratory evaluation, the aldosterone levels are low, we want to avoid spironolactone because it blocks the action of aldosterone. In someone who has a mild form of non-classic CAH, it should probably be okay, but that's something, you know, mainly to discuss with our patients. I don't typically jump into using spironolactone in those patients. I start with birth control pill, and then depending on, you know, how their presentation is, their electrolytes, maybe their steam test or the aldosterone levels, I may add a very low dose. It's not my go-to option. I don't prefer starting those patients, definitely not the ones who have the classic form of CH. In the non-classic form, I agree with Chantania in the chat that it should be okay, but definitely use it with a bit more caution compared to patients with PCOS. Okay, so case 3, 27-year-old woman is presented to clinic for evaluation of infertility. She had menarche at age 12, irregular cycles until the age of 14, when she started using combined oral contraceptive therapy. She continued her combined oral contraceptive therapy until she discontinued it 15 months ago when she started trying for pregnancy. On physical examination, her BMI is 29. She has mild to moderate hirsutism, and her laboratory evaluation shows a total testosterone of 45 with a DHAs of 418 and a day 3,7 hydroxyprogesterone of 2100 with a progesterone of 2. Before actually I show you the question, would anyone do a cortisol stimulation test in her? No, okay. Yeah, we do not need to do a cortisol stimulation test because her day 3,7 hydroxyprogesterone levels are already very, very high. They're above 1,000. We typically do when they're between 200 and 1,000 nanograms per DL. So based on this presentation, our question is, which therapy would you choose? Would you choose letrozole? Would you choose a combined oral contraceptive? Would you choose clomiphene, dexamethasone nightly, or hydrocortisone in divided doses? I see some people say E. Okay, someone says A. Okay, so for this question, I mean, the answer I've chosen is hydrocortisone in divided doses. A is not per se wrong. Just to clarify, so for that patient, we want to bring her follicular level progesterone lower. So we would start either hydrocortisone or prednisone. Sometimes it's just easier to use because it's a single dose. And then in addition to that, if we need to do ovulation induction, then we would do as we do with patients who have PCOS. So in that case, we would do ovulation induction with letrozole or clomiphene plus an IUI. Could someone want to share why D is not the right answer? Why not give dexamethasone? Would it be another option? Would it be okay to give dexamethasone at a low dose? Or may I ask it differently? How does dexamethasone differ compared to, let's say, hydrocortisone and prednisone when we think about someone trying to get pregnant? Let me see. Yeah, I mean, crosses the placenta. Yeah, we see that from the Q&A box. Perfect. And the chat. So dexamethasone crosses the placenta. So we want to avoid, it's a more potent glucocorticosteroid that crosses the placenta. So in those cases, we want to avoid dexamethasone. Either hydrocortisone or prednisone are fine. So, and then with that in mind, let's review a little bit treatment. When do we treat and what do we use for treatment? So, I mean, we all know in the classic form of CAH, people have adrenal insufficiency. We want to treat with glucocorticosteroids and mineral corticosteroids. Ideally, we want to avoid potent glucocorticosteroids. Sometimes when people are not very well controlled, sometimes we may need to add a little bit of more potent glucocorticosteroid, but we overall try to avoid it because we wanted to avoid signs of glucocorticoid excess. And same with mineralocorticoid deficiency excess. Now, in people who have non-classic CAH, who do we treat? And do we treat everyone? So we would treat children and adolescent patients with early onset and rapid progression of puberty or bone age if we think that the excess androgen are leading to a faster closure of the epiphyseal bones. And we would treat women with either hyperandrogenism or infertility. Who we would not treat? We will not treat males. Exceptions may be infertility or testicular adrenal rest tumors, but that is way less common in people who have the non-classic form. And we will not treat asymptomatic, non-pregnant patients with non-classic CAH. We will not treat patients with a non-classic form of CAH who are pregnant and they did not require any therapy before. So just to go back to the prior question about the birth control pill or the combined oral contraceptive pill compared to glucocorticosteroids in the non-classic CAH form. There have been a lot of studies looking into that. A more recent one was a study that looked at outcomes of 3 treatment groups. So they look at people who with a non-classic CAH form who received glucocorticosteroids, a group who received oral contraceptives, or a group who received both. A rate of hirsutism declined significantly, mainly in the oral contraceptive pill group, and the rate of acne declined in both the combined with a similar tendency in the oral contraceptive group. Given that sometimes giving glucocorticosteroids or needing to increase the dose may lead to side effects of glucocorticoid excess in our patients with a non-classic CAH, overall, we prefer treatment with combined oral contraceptive pills when people present with complaints of hyperandrogenism or irregular menses. Now, when it comes to fertility and pregnancy, there have been a couple of studies looking at rate of miscarriages and time to conception. So in this study, from now it's like been almost 2 decades ago, they had looked at 190 women with a non-classic form of CAH, of which 95 desired pregnancy. And there were 187 pregnancies that occurred in 85 women, which overall resulted in 141 births in 82 of them. So some pregnancies occurred before the diagnosis of a non-classic CAH, so they were able to compare the two groups. They found that the group that actually received glucocorticoid treatment had a rate of miscarriages at 6.5% compared to 26.3% who did not receive glucocorticoid therapy. So based on that, patients who may have recurrent miscarriages and they try, and they present with a non-classic form of CAH, we can advise them to start a very low dose glucocorticoid therapy. Now, because having one miscarriage is very, very common, in like 1 in 4 pregnancies in the general population will lead to miscarriage. That's something that I do discuss with my patients who may present with one miscarriage. And sometimes we just monitor to see how the second pregnancy will go. But if they're more worried about it, if they have other risk factors that may lead to recurrent miscarriages, we may start glucocorticoid therapy even before 2 miscarriages occur. Now, similarly to that, in another study that looked at fertility and pregnancy outcomes in patients with non-classic form of CAH, they looked at 75 women who were diagnosed with this condition and they showed fertility, and 72 women succeeded in conceiving. And it was actually shown that the women who received glucocorticoid therapy had a shorter time to conceive compared to the ones that they did not. So time to conception before therapy was initiated was on average 10 months, even though we can see the standard deviation is very, very high. It's like 12 months compared to 3 months after therapy initiation. Again, that did not actually affect the live birth. It was similar between the two groups, but for people who may be trying to conceive for longer than 12 months, also depending on the age of our patient, longer than 12 months for women who are younger than 35, or longer than 6 months for women who are older than 35 years old, we can add a glucocorticoid therapy. And in addition to that, after we've all added glucocorticoid therapy, then we can always, plan ovulation induction therapy plan as we would typically do with either clomiphene, letrozole, and IUI, and then, move on to gonadotropin therapy if needed and IVF. Now, again, the main goal for people who are trying for pregnancy, who have non-classic CAH and they seek fertility treatment, or they have history of miscarriages, is to have a follicular level of progesterone less than 0.6. And so for my patients who have non-classic form of CAH and they already have a low follicular level of progesterone, let's say have a 0.2 or 0.3, I discuss with them that maybe like adding a glucocorticoid therapy a glucocorticoid pill in the regimen may not add as much. So that's something that we should definitely monitor before and after starting therapy, because our goal is, even after we start treatment with hydrocortisone, after we start treatment with prednisone, is to check a progesterone level in the follicular phase and make sure it's suppressed less than 0.6. And then, as we discussed, we want to avoid dexamethasone because it crosses the placenta. And then if a woman is diagnosed with non-classic CAH and becomes pregnant in the absence of glucocorticoid treatment, we do not need to start during pregnancy. And treatment should continue throughout pregnancy. Having said that, we want to make sure, even though most of my patients have been maintained on the same dose from beginning of pregnancy until delivery, we want to keep in our minds that there are changes that happen in the hypothalamic pituitary adrenal axis in pregnancy. So pregnancy is a state of increased HPA's axis function. So we have elevations in, for sure, total cortisol, mainly because the CBG levels go up, but we have increased levels of free cortisol and increased levels of ACTH. So as the pregnancy progresses, we want to make sure we assess our patient's electrolytes, we assess our patient's symptoms, and if need to slowly increase the glucocorticoid doses, especially after 20 or 30 weeks of gestation. Now, in general, we monitor therapy based on the clinical presentations in both of our male and female patients, both who have both classic and non-classic form of CAH. So main things we want to make sure when our patients present to clinic for follow-up is that we assess their volume status. We want to assess for signs of glucocorticoid and mineralocorticoid excess. We definitely measure their electrolytes. Goal is for them to be a normal range. And we always check testosterone. We can check androstenedione, and especially for men, because it's like mainly adrenal, we want to make sure that the goal is less than half of the testosterone level. What I want everyone to remember is that 7-hydroxyprogesterone can be variable, and we don't routinely measure it in follow-up appointments after we start treatment. Having said that, if we are suspecting that someone is overtreated with glucocorticosteroids, we can check a 7-hydroxyprogesterone level, and if it's suppressed or if it's normal, then that's a sign that we are overtreating our patient. Main goal in terms of like men who have CAH is like maintaining testicular function. So we want to make sure gonadotropins are in normal range. We don't want them suppressed. Suppressed gonadotropins mean that the adrenal androgen are producing excess, and they're suppressing LH and FSH. On the other hand, very high LH and FSH are indicative of testicular atrophy, which can happen in the setting of testicular adrenal rest tumors. And for women who are trying to conceive, as we discussed, the goal of the follicular phase progesterone is 0.6 nanograms per ml. So I see here there's a question, there are a couple of questions in the chat. Okay, so Julie is asking, how can you be sure when the follicular phase is, when the patient has oligomenorrhea? That is a great question. So first of all, if we check a 7-hydroxyprogesterone, let's say the patient has oligomenorrhea, she had her last menstrual period 2 months ago or more than 35 days ago, so we don't know where she's in the cycle. And you check a 7-hydroxyprogesterone level and a progesterone level, and those are low. That's reassuring. The question arises when those are high. Is the patient ovulating? Is she not ovulating? So one easy way to assess that is that if you get a 17-hydroxyprogesterone and a progesterone level that are indicative of luteal phase levels, the patient should be expected to have a menstrual cycle in the next 7 to 10 days. So a way is like to monitor them, bring them back in clinic in 7 to 10 days, or be in touch with them, ask them, have you have a menstrual cycle, like a menstrual period or not? As we know, once someone has ovulated, a menstrual period will appear 14 days later. So if that was a true luteal phase progesterone or a luteal phase 7-hydroxyprogesterone, they should have their period in the next 14 days, like 7 to 10 days, especially if you capture them a little bit after ovulation. Now, if your question is that I have a patient who presents, she hasn't had a period for the past 40 to 50 days, how should I get labs? How do I know I'm in the luteal phase, I'm in the follicular? In that case, sometimes giving them medroxyprogesterone, like the Provera challenge, giving them 10 milligrams of Provera for 10 days, wait for them to have the withdrawal bleed and check labs then on day 3 of that induced bleeding would be the way to go to assess for day 3 labs. I hope that answers your question, Julia. Let me know if anything was not clear. Then Louise is asking, any recommendations if the fetus is female, assuming the father is not a carrier? So if we know, so I guess you mean someone has non-classic CAH or even classic CAH, and we know the father is not a carrier. So then the fetus we know will not have, the main risk for the fetus is to know whether they will be born with the classic form of CAH, because we're worried about salt wasting crisis. But even with a severe form of the non-classical form, they may have virilization as newborns. So if the father is not a carrier, then there is no, because this is an autosomal recessive disease, for a patient to have CAH, they need to have inherited one allele from mother, one allele from father. If we know the patient is not, the father is not a carrier, there is no chance the fetus will have CAH. The fetus will be a carrier of one of the 2 alleles from mom, but that will not lead to a salt wasting crisis or the classic form of CAH, for sure not. Now, there are some experimental studies, and they used to be recommended many years ago, that women who have children at increased risk for CAH, or even the non-classic form, they should be treated with dexamethasone that crosses the placenta with the goal to decrease the ACTH in the fetus and prevent virilization of a female fetus, of a female baby at birth. And then they would wait for, an amniocentesis to see whether the karyotype was 46XX or 46XY, to know whether the fetus was female or male. If it was male, it would be recommended to stop. If it was female, it would be recommended to continue. Having said that, more recent data have shown that, first of all, we can do like the cell-free DNA testing to know what the karyotype is a bit earlier. And this treatment is overall not recommended because, first of all, dexamethasone is a more potent glucocorticosteroid and can increase the risk of gestational diabetes, of preeclampsia, eclampsia, and puts pregnancy overall at risk. So it is not a recommended treatment method for this first reason. The second reason is that there have been studies in patients who have either classic form of CAH and non-classic form of CAH who received dexamethasone through the placenta as newborns. And it has been shown that that's linked to decreased cognitive function and decreased IQ later on. So overall, because the chances, it's like a lot of variables there to have a female fetus, to your partner to have the risk. That's why genetic testing in both partners is important. Overall, it's not a recommended strategy. It's still an experimental method. And I guess if you have a couple where their chances are very high, they're both carriers of the alleles, that's something that you can reach out to a center who does experimental treatment like that. But overall, it's not in the recommendations for both because it increases the risk of a complicating pregnancy. And there have been some studies showing long-term effects in those people born with CAH in terms of their cognitive function, but also their metabolic status. I hope this addresses, Louise, your question. Please let me know in the chat or unmute if something is unclear. So Denise, is it necessary to prescribe hydrocortisone or prednisolone 5 milligrams with heterozygous form for planning pregnancy during a pregnancy? Okay, so the recommendations for hydrocortisone so it's hydrocortisone or prednisone. Prednisolone is a little bit more potent, so it's either hydrocortisone that we give or prednisone. Sometimes we can give prednisolone if they have very high progesterone levels and we cannot suppress less than 0.6. But for patients who are carriers, so have only one affected allele, typically, to be honest, we don't even capture those patients at clinic because they may have a very, very low rates of hirsutism. Very rarely we have irregular cycles. So most of the people in the general population who are carriers of non-classic CAH, they have never been diagnosed and they go through like healthy pregnancies and healthy newborns. But if you do, and if you capture someone who is a carrier of the non-classic CAH, again, the guidance would be checking the follicular level progesterone, the follicular phase progesterone level. And if it's less than 0.6, then it's okay not to treat. Sometimes, we are wondering at clinic, could some people with PCOS who have signs of irregular cycles, severe hirsutism, they had a 17-hydroxyprogesterone, like 120, steam went up to 500. So it did not pass the 1,000 cutoff. Could those be carriers of the non-classic CAH? That's why their 17-hydroxyprogesterone levels steam to the 600s and not into the 400s, as we typically see. It is a possibility. And I do discuss this with my patients. But again, because they are carriers, chances would be that their partner would also need to be a carrier to have a 25% chance of having a child with CAH. And so, again, in that case, Denise, I would go with a follicular phase level progesterone to kind of like guide treatment. Okay, so I don't see any more questions for now. So let me go actually to our last case. And then we're going to also have some more time for questions at the end. So a 32-year-old male with a now classic CAH presents at clinic. He was diagnosed early after birth. He has been treated with 15 milligrams of hydrocortisone in the morning, 10 milligrams in the afternoon, and 0.1 of fludrocortisone. And while he was transitioning, to his adult care, to his adulthood and early adulthood, he has not been very compliant with therapy. And on physical exam, you palpate bilateral testicular tumors. What is the next best step? Do you want to do a testicular biopsy, check HCG and AFP, increase the fludrocortisone dose, add a potent glucocorticoid, refer to surgery? I see a B, Denise says B. Any other thoughts? Okay, Leslie says B. Shantea says D. Lizette says B. D. So we get a lot of B and Ds. Okay, good. So here, in terms of the best next step would be to add a potent glucocorticoid. mainly because we suspect testicular adrenal rest tumors. Now, this is kind of like a board style questions where in reality, if you palpate tumors, you want to make sure it's not something malignant. So you also want to do both B and D, to be honest. So I will give the correct answer to everyone, because you also want to make sure you're not missing a malignant tumor in the testicles, even though in that case, it would be more unilateral if it's a malignant tumor. Having said that, in real life, in clinic, you would always check markers. But based on the patient's history, what is the condition that we think this patient has? If someone can TART, yes, perfect. So again, males with basically with the classic form of CAH, we are suspecting patients will have testicular adrenal rest tumors. So TARTs are believed to be derived by ectopic adrenal cortex remnants in the testes or from reprogrammed Leydig stem cells, which differentiate and grow under the influence of chronically elevated ACTH. TARTs are firm, are irregular. Most of the times we can palpate them on physical exam. Having said that, getting an ultrasound is the more specific way to detect them because they can be missed. And for people who have the classic form of CAH, they can occur in 30 to 50% of them. And the main consequence those have is that they can cause pain, but they can also affect fertility. So there have been studies showing that intensifying glucocorticoid therapy, but not surgery, might restore fertility. And most of the times we want to add a potent glucocorticoid like dexamethasone or methylprednisolone at a very low dose at bedtime to kind of like in an effort to decrease ACTH. And as we discussed earlier, it is important for those patients to check LH and FSH. And if those are high, it means that the TARs have actually caused some atrophy in the testicles, leading to kind of like in addition to the CAH, adding like a primary testicular failure. They are benign, so you assure your patients that those are benign. Of course, we want to make sure we exclude malignancy, as people said in the chat, with the markers. But they also lead to obstructive azoospermia and infertility. And it is a predictor for infertility. And usually those regress after we intensify glucocorticoid therapy if detected early. And this is the reason why we start screening from adolescent years. And we always recommend, or we always do testicular exam during physical exam at clinic, but also always get annual testicular ultrasounds. And, when tumors rarely are unresponsive to intensifying glucocorticoid therapy, we can do a testicular sperm extraction. And this is a discussion I do have with my male patients with the classic CAH at clinic, especially, where they're adolescents, like young adults that, if you're interested, maybe like doing a semen analysis now or do some sperm cryopreservation, because especially for people who have the classic form of CAH, in about 50% of them will develop those tumors and it will affect their fertility in the future. Now, we don't have available data in men who have the non-classic form of CAH, so we don't know if TARs are a feature, and that's why we don't give prophylactic glucocorticoids. To be honest, it is very rare to come across a male with a non-classic form of CAH. Sometimes when they present in childhood with premature adrenarche, but because they're pretty asymptomatic, it's not like women with a non-classic form of CAH that will present with irregular periods or hirsutism, things that have PCOS. In men, it's a little bit more difficult. So it's like tougher to detect this subpopulation of patients at clinic to begin with. And then this is the discussion I do have with men with the classic CAH at clinic. So they're more prone to develop oligospermia and infertility, and especially in the setting of chronic glucocorticoid added treatment. And that's why we need to check androstenedione, testosterone, LH, and FSH every time they follow up at clinic, because low LH and FSH means that adrenal-derived androgens are still high. They suppress gonadotropins, and they lead to low testosterone production from Leydig cells. And that's a sign of undertreatment. And the second reason for the infertility, increased risk for infertility, is that half cases, like 50% of men with the classic CAH, will develop TARDS. So I know we have a few more minutes left, so I will very briefly go over a couple of slides. These are the last slides. Mainly discussing some more recent therapies that have been designed and they are in trial phases for CAH. So a few years ago, there was a single-blind, placebo-controlled, single-dose trial of 8 women with the classic form of CAH, where the investigators tested a selective corticotropin, CRH, releasing hormone receptor type 1 antagonist. So the goal is like to block the CRH action into the effect of ACTH. And, this drug was given in 2 different doses, 300 milligrams and 600 milligrams. Here that we can see the lines here compared to placebo. And then 16 hours into the study, hydrocortisone was given to actually follow up the response of ACTH and 17-hydroxyprogesterone. And you see with the use of those antagonists, ACTH levels did not increase, were much lower compared to placebo, same with the 17-hydroxyprogesterone levels. And most recent, now 2 years ago, different doses and regimens of the same medication were tested. So there was like 50 milligrams once daily, 100 milligrams once daily, 100 milligrams in the evening compared to the bedtime, and 100 milligrams twice daily. And we can see that with all doses, ACTH level were significantly lower compared to placebo. Same with the 17-hydroxyprogesterone levels and the androstenedione. And that was I believe that was a phase 2 trial. There were also the safety of the medication was tested. And overall, there were no major severe adverse outcomes that were related to the trial medication. And it was mainly some malaise, some fatigue, fever that was reported during the study, and some nausea. In addition to that, there is a modified release formulation of hydrocortisone that I believe now is available in the UK and Europe. It's not available in the United States yet. That has overall been shown to have a good effect in suppressing 17-hydroxyprogesterone levels and androstenedione. So we know that, it's the rise in ACTH, especially in the morning, that it's linked to some of the symptoms that our patients experience. And most of the time, especially for the ones who have the classic form of CAH, mainly for them, we have some difficulty controlling the symptoms with the divided doses. So having a longer, like modified release formulation of hydrocortisone that has a delay release action given twice daily has been tried, and then we see that it had a good effect in suppressing or keeping the 17-hydroxyprogesterone levels into the normal range. Same with the androstenedione. And that was a 6-month randomized phase 3 trial that I'm showing here, and now it has received approval in UK and other European countries. And with that, I know we are close to 6 p.m. We have 2 minutes left. But I want to conclude, and then we can, I'm going to stay on for questions, but some take-home points, things that I'm sure that, when we assess for irregular menstrual cycles, we always need to assess for chronic ovulation, ovarian causes of ovulation, hypothalamic causes, and anatomic abnormalities. And as you all mentioned at the beginning, we need to get a very detailed medical history and physical exam. And when it comes now to the second part of the talk, where we focus mostly on the classic and non-classic forms of CAH, we know that the classic form of CAH is a life-threatening condition, and it is usually diagnosed at newborn screen, whereas the non-classic form of CAH is something that we see at the adult reproductive endocrine clinics in women with hirsutism, irregular cycles, and infertility. And screening with a 17-hydroxyprogesterone level during the follicular phase is the way to go, and using the cortosis stimulation testing when needed for confirmation. And remember that treatment for the non-classic form is not recommended in all patients. For people who have hyperandrogenism, we prefer the combined oral contraceptives. Those desiring fertility can be treated also with glucocorticosteroids. And with that, I'm gonna stay on for any questions people may have. And and then yeah, I can stay on if people have any questions, if you want to unmute, if you want to type them in the chat. I know tomorrow you're going to have a full day on adrenal and reproductive endocrinology. And I have entered my email also if there are any questions after the course is completed, either in, oh, and thank you, yeah, it's also in the chat. Perfect. Either generally asking questions or specific cases, I'm more than happy, you know, to share thoughts. So thank you everyone for listening. And yeah, I will stay on for a few minutes too if people have questions.